your seats. We still have a few people coming in. So great to have you all here. We'd like to get started. We've got an action-packed program for you tonight. We're so happy that you're all here. There's plenty of seats up front. Got a whole row back here. Why does no one like to sit in the front row? Come join us. We'll let everyone get settled. Thank you. Thank you for joining us. Ladies and gentlemen, distinguished guests, esteemed speakers, the many of you who are watching online, thank you for joining us today for our public briefing, Advancing UHC and Pandemic Preparedness and Ending Tuberculosis, here with Foreign Policy and IFPMA, our great partners in this venture. We thank you so much for joining us. I am Andrew Solinger. I am the publisher and CEO of Foreign Policy, and it is my honor to kick off this discussion, which is incredibly important, the pressing need for progress on UHC, pandemic prevention and preparedness and response, and ending the tuberculosis pandemic. UN member states met today and tomorrow to discuss UHC, PPR, and TB declarations up for endorsement at the high-level UN meetings that will be taking place this fall. But our aim tonight, and a few of you have asked me what our aim tonight is to address a crucial question. How can we foster sustainable and thriving innovation ecosystems for healthcare that support UHC and better pandemic preparedness? To answer this, we've partnered with the International Pharmaceutical Manufacturers and Associations, IFPMA, which is the body that represents the pharmaceutical industry in official relations with the UN, and we're very happy that they're here convening tonight's program. We've gathered experts from various fields, including public health, multilateral agencies, and the private sector to share their insights and discuss challenges, opportunities, and strategies for advancing global health objectives. This is all underpinned by research that was conducted in the past month and several weeks by FP Analytics, which is the independent research arm of Foreign Policy. And you will find that research on your seats printed out for you in a blue booklet. But we also have a QR card that you can use to zap and see it online as well, and we encourage you to do that. And for those of you who are watching online, you could see that online as well. We'll delve into the lessons learned from the COVID-19 pandemic, and we're going to explore how we can foster better collaboration between countries and organizations and enhance healthcare infrastructure and health equity. And our aim is to spark thoughtful conversations and dialogue to foment positive change in global health policy. So we are going to take questions tonight. My colleagues have microphones that they will be have available to you, and we encourage you to raise your hand, ask a question, and help guide the conversation. And for those of you watching at home, you can click on the question button and submit a question, and my colleagues here will forward that question to us on the dais, so we'll be able to address that as well. So please do submit that. A few other housekeeping items. We encourage you to engage in the discussions online and on social, and you can do that using the hashtag Innovation for Health. That's innovation number 4, health. And again, I really am very pleased to start this off. So let's begin our exploration of the critical issues around global health care right now. We'll start right now. So to start, I'd like to invite Ambassador Kimihiro Ishikani to join me. He is the permanent representative of Japan to the UN. He assumed this role in 2019, but he has many years of experience in the Ministry of Foreign Affairs. Ambassador, if you could join me, please.
Thank you. Thank you, Andrew.
So nice to see you. So, Ambassador, thank you again for joining us. It's actually very exciting to have you here as Japan is preparing to host the G7 in Hiroshima later this month. And interestingly, there are many problems, severe problems in the world today. We have a war in Ukraine, heightened geopolitical competition and the threat of war. We have energy crises, food crises, financial crises. But Japan has chosen to make UHC, universal health care, and human security a key element and a central pillar of the G7 summit. Why is that? Why such a big focus on UHC?
Andrew, thank you for asking me that question. As everybody knows, Japan is hosting a G7 Hiroshima summit from 19th of May till the 21st. Of course, under the current circumstances, I cannot think of any other better place to hold G7 summits where the G7 leaders get together to think about the peace, which is now under stress. So I'm hoping that G7 leaders will come up with a robust message of peace, upholding the rule of law. But I think at the very same time, we need to think about other challenges. The challenges developing countries, vulnerables, are facing. The challenges of pandemic, which is exacerbated by the complication brought about by the war in Ukraine. And of course, there is a climate change crisis. And there are so many other challenges which developing countries are facing. So I think G7 summit meeting in Hiroshima, by the way, the health ministers meeting will be held in Nagasaki. Mm-hmm. So that summit meeting in Hiroshima will be a good opportunity for G7 leaders to discuss about those challenges which vulnerable countries and developing countries are facing. And the health is one of the I think most important element that really underpins the effort of all of us, by which we try to overcome the challenges we face. As a matter of fact, Japan had an experience right after the end of the Second World War. We faced the challenge of tuberculosis, but we overcome that challenges. Of course, thanks to the efforts of many Japanese, but also thanks to the collaborations or assistance extended by the international community. So that's one thing. But at the very same time, we try to come up with what we call universal health coverage, by which we enable everyone to have affordable access to the basic health care in Japan. And that was achieved in the year 1961. Maybe this year coincided with almost the end of the post-war period. But anyway, with that in place, Japan could achieve economic growth, which we have witnessed afterwards. So we believe that putting the universal health coverage in place would be a very important basic infrastructure for each country to grow economically. Thank you.
Fascinating. Great to learn from the lesson of Japan following World War II and the tremendous economic success attributed in part by the ambassador to universal health care. Prime Minister Kishida wrote in The Lancet earlier this year that global health should be based on human security. He described 3 pillars of focus. One of them was UHC, as you just described. The others were global health architecture and technology innovation. Can you tell us a little bit more about each of those, the importance of health architecture and technology innovation?
Yes. Well, if we learn lessons from the COVID, I think there are a couple of things. First, it's about the importance of solidarity, of course. No one is safe until everyone is safe. As a matter of fact, personally, when the COVID outbreak took place, I thought this will be a moment of Independence Day, the movie. But that never took place. There was just finger pointing instead. Of course, afterwards, people, thanks to the efforts of many people, we could come up with the invention of the many vaccines and distribution of that. Of course, there are so many problems. But anyway, the number one lesson is solidarity. Number 2 is equitable distribution. But here, I think number 2 is the equitable distribution, but which can be ensured by the global health architecture. As I'm not a health super expert, I put it this way: global health architecture start with the detection of the crisis, and the sharing information with others, and taking preventive measures, and the invention of vaccines or therapeutics, and the production in quantity of the newly invented vaccines, and the distribution of that vaccines. So this is a whole set of, system which should be in place. Of course, when we faced the challenge of COVID-19, everybody did their best. I think thanks to the effort, we are here without having no mask here. But still, things have been much better if there was a better coordination, if there was a kind of architecture in place. So that's why we put much importance on this global health architecture.
Great. And how about, we talked about technology a little bit. How about funding? It was a huge issue during COVID-19. How can we ensure we have adequate financing available for the next pandemic?
Well, the financing is a huge problem because that's also another, other lesson we have learned through COVID. Of course, generally speaking, each country should think very seriously about the sufficient funding to this kind of preparation and in tackling with the newly emerged pandemic and so forth. So we need to invest money, invest the human resources, and we need to invest financial resources because it is for the national interest, mid-term and long-term national interest of each country. But saying that is easy. Of course, each country has its own problems. Same here in Japan. How can we, move ahead with that? There comes in, a lot of kind of, wisdoms which we have, deployed. So, for example, first, year 2019, yes, that was year 2019, when Japan organized a G20 summit meeting in Japan. We organized for the first time the ministerial meeting, which combines the finance ministers and health ministers. This combination of finance ministers and health ministers give a kind of impetus to keep things move forward. And I think this kind of things has to be more exalted because this will give another impetus to the to operationalize the what we call a pandemic fund, which was established at the G20 afterwards 2021. So this year Japan will talk about this kind of cooperation between the finance ministers and health ministers. But apart from that, we need to think about many other things. Private-public partnerships.
This was my next question.
Oh, that was it.
Yes, absolutely. In addition to financing,
yes,
how can government and private enterprise work more closely together? It ultimately did work, but not right away. How can we work more closely in the next pandemic?
Because R&D for preparing for the next possible pandemic requires a huge amount of money. But this does not really fall in the play of market mechanism perfectly, because I don't say it's a market failure, but market mechanism is not sufficient to cope with this situation.
Right.
So here the public sector should come in. So here the public-private partnership should be more promoted. There are a couple of examples. There's R&D supported by CEPI, Coalition for Epidemic Preparedness Innovations, which was launched at I think the Davos conference 2017, to which Japan is one of the major contributors. And this R&D supported by CEPI accelerated the invention of many therapeutics or vaccines, starting with Ebola, SARS, and I'm told that this has made some certain contribution to the invention of the Moderna vaccine as well. And another example is, this is very much Japanese. We call it GHIT, which stands for the Global Health Innovative Technology Fund, which combines the resource of Japanese government and the Gates Foundation, as well as pharmaceutical companies. So with the combination of those three different players, we try to promote, the invention or production and distribution of especially neglected tropical diseases or TB and malaria and so forth. So these are the things, the ideas of how we can bring in the private sector's, energy into play. But once again, if we leave it just to the market mechanism, it will not work out as we expect it should be.
Thank you, Ambassador. And we've run out of time, unfortunately, but it's very heartening to hear the example being set by Japan and the history that Japan has had post-war with TB, universal health care coverage, economic boom, and having the foresight to make that a key pillar of the G7 meetings in Hiroshima. Thank you so much for spending time with us today. We really appreciate it. Thank you again. The Ambassador.
Thank you.
Thank you, sir. I'd now like to introduce my colleague, Dr. Maisha Alam, who is the VP of Research at FP Analytics, which wrote the fantastic report on the seats in front of you. She's going to lead a discussion on PPR with Priya Basu, Executive Head of the Pandemic Fund Secretariat and the World Bank at the World Bank Group, and Hamilton Bennett, Senior Director of Vaccine Access and Partnerships at Moderna. Please.
Thank you, Andrew, and hi again, everyone, and welcome. We're so delighted to have you here. And as Andrew mentioned, my name is Maisha Alam. I'm Vice President of Research at FP Analytics, and I'm honored to be joined now for this chat with two incredible leaders. Next to me, I have Hamilton Bennett, who is the Senior Director of Vaccine Access and Partnerships at Moderna. And in this role, Hamilton and I, we were just speaking about this before we came on stage, she led the COVID-19 vaccine development program team that was eventually developed and managed to get to the authorized use and approval of Moderna's COVID-19 vaccine. And so I can't think of somebody who has more experience and expertise. Yes, absolutely.
Thank you.
And so we're so delighted to have her with us and really excited to hear more from her. On your screens, we also have Priya Basu, who is the executive head of the Secretariat for the Pandemic Fund, hosted by the World Bank. And in this role, she leads the World Bank's engagement on pandemic prevention, preparedness, and response in global health fora like the G20 and G7. So a perfect segue from our previous conversation. Priya has very, very kindly joined us from Italy, where she is, and where it is currently the middle of the night. So Priya, we can't thank you enough for your commitment to this issue and for staying up late to join us in this conversation. Can you hear us all right?
Yes, I can. Thank you, and great to be with you today.
Fantastic. Well, I'd love to start with a question to both of you, and would love to hear from your perspectives how you approach this, which is, what in your view are the most important lessons learned from COVID-19 that need to be integrated front and center for preparedness for future health emergencies?
I think we often forget that our response to COVID was based on decades of research in basic science and in platforms and public health technologies that allowed us to respond. And so I hope that through these conversations and others, what we end up bringing forward is a continued commitment in that investment pre-pandemic. Because I ultimately think that while our response to COVID took a year, it would have taken much longer had we not invested in that preparedness up front. And I also think that one of the best things that came out of COVID was the innovation in the way that we engage collaborators, the way that we engage regulators, and the way that we think about the community of response. Mm-hmm. And I think that becomes more and more important as we exist on this global scale and we see the global impact of pandemics. But we saw, small biotech and large pharma collaborating with each other, private industry and public collaborating, all towards this shared goal of trying to end the pandemic as quickly as possible. And that allowed us to innovate in surveillance and disease testing. So now wastewater treatment and wastewater testing is kind of common. At-home diagnostics are common, and there's an expectation that they'll become more prevalent for future seasonal and outbreak diseases. And the ability to develop multiple vaccines in less than a year is something that I don't think any of us thought was possible before, but it happens when you have this incredible collaboration and this shared mission and understanding of what you could do if we were able to innovate towards it.
Picking up on something that you said, you've mentioned the community of response that's necessary, and obviously multilateral institutions, and in particular the World Bank, has a very important role in this. So Priya, let me bring you into the conversation, and from your vantage point, what are the most important lessons learned to integrate for future preparedness?
No, thank you, and great to be here. So yes, I mean, I agree with what Hamilton said, and I think it's worth saying that, and it's worth remembering that the world really was quite seriously ill-prepared at so many levels, and we learned from COVID that we really cannot afford to be this ill-prepared again. We can't let this happen again. So that's kind of one big message that I do want to share, because COVID is already becoming a thing of the past in many forums. So it's important to just keep that focus. I think staying with vaccines, I just want to make, so I'm going to talk about three lessons. One, on the vaccine front, indeed, I think, it was so encouraging to see how quickly vaccines were developed. And so that's kind of the good news coming out of COVID, that the world has the capacity to do that, to collaborate between private, public, academia, and get these vaccines, at such speed. But I think, on the other side, I just want to sort of emphasize that one big lesson is that the next time round, we have to ensure that everyone has equitable, timely, affordable access to vaccines and other medical countermeasures. So from where I sit, a lot of my time over the past 3 years was really to try to ensure that the poorest countries of the world, got access. And I'm afraid, we could have done better as the international community, as public sector and private sector working together to make that happen. So one big lesson: geographically distributed manufacturing capacity for vaccines and other medical countermeasures, procurement capacity so that low and middle income countries can procure these vaccines in a timely manner at affordable prices. And then let's not forget last mile delivery, getting shots into people's arms, the cold chain, the infrastructure, the logistics, the trained vaccinators. And then maybe in that piece again, thinking about the export restrictions, how can we make sure that that raw materials and finished products can move more quickly across countries, and that there's regulatory harmonization. So that's one piece. Then my second big lesson is that preparedness has really been chronically underfunded, and there are really quite significant gaps in low and middle income countries in particular to be filled in order to, as Hamilton said, to make sure that they have the capacity to prevent, detect, report, contain new outbreaks, emerging outbreaks, and investments in surveillance and labs and testing and workforce. The World Bank, together with the WHO, did a study last year for the G20 where we estimated that about $30 billion per year over the next 5 years is needed for low and middle income countries to fill those gaps. These investments are a fraction in comparison to the cost of not being prepared, the trillions of dollars that that the world has lost, and not to mention the lives lost. And then third big lesson, the ambassador mentioned this as well, and it cannot be underemphasized, global solidarity and partnerships are vital in all of this. And at the country level, leadership and political will and trust. So those are my big lessons that I just want to share. Thanks.
Thank you. And there's so much to unpack there, Priya. And, you know, as I'm listening to you speak, one of the things that I think is really important to underscore is that we're talking about an entire ecosystem, right? So there's the medical response, there's the infrastructure, the supply chain resilience. There's so many different components. And you rightfully went to one of the key issues. You went kind of right to the heart of it, which is about equitable access. And I'd love to pick up on that thread, Hamilton, and go to you next. And in particular, ask you, you know, from your vantage point, and again, being in an incredible leadership position at Moderna, which has been such a hub of innovation and advancement, how do we balance intellectual property rights in fostering an innovation while also ensuring equitable access to life-saving treatments and vaccines, especially in low and middle income countries, during public health emergencies and during pandemics? How do we strike a balance and make it better in the future?
I think it starts with interrogating the causes of that inequity in access. And I think a lot of it is if you look, as you mentioned, across the supply chain and across what is required to bring vaccines, therapeutics, diagnostics forward. What we've learned in pandemics is they're not causing health inequities, but they're exacerbated by health inequities. And we really need to be creating health ecosystems that are addressing those large systemic gaps. Intellectual property is a way that we in the pharma industry kind of incentivize that innovation that happens in the pre-pandemic time period. There are billions of private dollars that are invested in these innovative technologies that allow them to be ready to respond when necessary. And what we need to be thinking about is how do we make sure that that technology is accessible and available to low middle income countries. And we can do that through a variety of mechanisms, including licensing, including tech transfer. But at the heart of them, we have to find ways that incentivize innovation and incentivize that private investment and that risk-taking that happens before that response is necessary. As we think about where we were in 2020, we didn't know that we were entering a 3-year global public health emergency. There was a lot of talk that COVID was a seasonal outbreak and that it would go away as the spring turned into the summer. But we still needed to find a way that companies and pharmaceutical companies around the world were going to take their resources and divert them towards this unknown threat. And hundreds of companies stood up. You had over 120 vaccines in development within the first 5 months of 2020. And that's an incredible response from the community. But we need to find ways to incentivize that and to build markets and ecosystems that take that capital risk into account.
Something that you said that I think is so interesting is so often I feel like it's during a crisis or during a prolonged emergency where people are focused, but then the momentum shifts and it falls. And listening to you both speak, what I'm hearing over and over again is the interpandemic years are really, really important. And to pick up on that theme of innovation, a question for both of you, which is, what does collaboration and collaborative innovation between the private sector and multilateral institutions look like when it comes to pandemic preparedness and response? So, for example, how did Moderna and the World Bank work together to contribute to the development and distribution of COVID-19 vaccines, and what can be done similarly and also differently in the future? Priya, maybe we'll start with you this time.
Sure. So I think, just to say again, public-private partnership and collaboration is absolutely critical at many levels. And maybe I can just maybe briefly mention the pandemic fund, since it was raised by the ambassador as well and by you. So, this is kind of really a great example of how stakeholders from governments, from philanthropies, foundations, international organizations, civil society came together really so quickly in less than 6 months in the midst of a pandemic, and put together, put up $1.7 billion to set up the pandemic fund in late 2022. So as far as the funding is concerned, an example of how public and private sector came together, we have a number of sovereign donors, and we have philanthropies and foundations bringing their money and their expertise. It's the only multilateral fund that's dedicated to pandemic prevention, preparedness, and response. So it's quite unique in what it does. There are many actors, many international organizations that focus on PPR, if I can use an acronym, but this is the only one that's dedicated. And then the way in which we're investing in low and middle income countries also brings together the public and the private sector. Our approach is very much the need for a multi-sectoral, multi-stakeholder approach. We recognize that pandemic prevention, preparedness, response requires focusing on health, on environment, on animal husbandry, bringing together health, finance, environment ministries, bringing together the private sector in delivering these projects, making sure that every dollar of funding that we provide complements what others are doing on the ground, incentivizes both governments and private actors to come forward, bring coordination among partners. So this is kind of a really good example. We're still very new. We've just announced our first call for proposals, which will close in a couple of weeks, and then we'll be able to share with you in a few months what these projects actually yielded. But the approach, I can assure you, is very collaborative and recognizes that everyone needs to come together. And then maybe one other quick example is that the World Bank also co-convenes with WHO and OECD the Universal Health Coverage 2030 multi-stakeholder platform. And within this, we host the private sector constituency, which comprises of 40+ companies ranging from pharma to medical equipment to service delivery to advanced UHC, working public and private sector together. So just a couple of examples. And then on your specific question of the World Bank and Moderna, well, in the course of COVID-19, the World Bank had a $20 billion facility for vaccines where we were helping countries helping low and middle income countries, our client countries, procure vaccines from wherever they were available. So there was a lot of collaboration with Moderna, Pfizer, J&J, but maybe Hamilton can elaborate on that.
Yeah. I mean, I hope people appreciate that when you're talking about what the pandemic fund needs to do, it's strengthening health systems, right? It's touching every aspect of how we view public health, because ultimately that's what vaccines are. They're part of a public health ecosystem. And what we can be doing now is strengthening those end-to-end, how do we research collaboratively pathogens towards pandemic preparedness and prototypes? How do we develop those in a way that engages regulatory authorities and stakeholders that will ultimately be distributing and administering vaccines and treatments to make sure that the product is acceptable and to make sure that the product is something that is appropriate for the population that is experiencing the burden of disease, and that we have an eye towards health equity through the development, through the manufacturing and distribution of these products. And that is a daunting task, but I think when you instead don't think about individual products, but you think about what's required to enable any of that, it allows you to see progress day in and day out and towards this preparedness that we speak of. So what you're layering is just a response to a specific outbreak or a specific pandemic on top of that healthcare system that we've built that is strengthening all of it.
It's so interesting to hear you both speak from your different vantage points, and I wanted to ask you both about the role of financing. And one of the things that we know from obviously the COVID-19 pandemic is that there was financing challenges, financing shortages, pledges and commitments, but not necessarily follow through. And so again, as we look to the future, as we look to the upcoming G7, the G20, UNGA, obviously where there's going to be these issues on the agenda as well, can you just close this segment by offering some reflections on what you think needs to happen in terms of mobilizing financing and getting it quickly where it needs to be?
Mm-hmm. access to flexible funding early on is critical for the procurement and distribution of any of these products that we're talking about. At least for Moderna, from our perspective, it was a small biotech company at the time this started. We were in the process of building manufacturing capacity. And so part of it is right-sizing that capacity and making sure that across the global players that we understand how much vaccine do we need to produce. And then with private investment supporting that capacity expansion, we needed to know who the buyers were. Where were we going to be able to distribute the product? And so that means that those people need access to flexible financing. And we saw that that was one of the limitations that unfortunately came to pass with COVAX. Well-intentioned, but when they can't secure access to funding, we start to see the impact of that, and it means that the countries that they are representing end up paying the price for the shortcomings in the funding. And I think that that's something that we are all acutely aware of, and we think about as we look forward to how do we improve equity of access in the future.
Yeah, Priya, we're just about at the end of time, but I do want to have your final reflection on this, which is, as I mentioned, how do we get financing rapidly and in a rapid and targeted way, dispersed to make change happen when it's necessary?
So I think, Hamilton's spoken about the rapid financing. I want to make a point about the need for sustained financing during interpandemic years, because, pandemic prevention, preparedness, and building capacity to respond, in peacetime, so to speak, between pandemics, that requires a lot of patience, and that requires, sustained investments. It's not a one-off. And it's challenging because these kinds of investments are not visible until the pandemic happens. It's not like building a road or a bridge. It's sort of making these investments so that when the pandemic strikes, the cost will be lower, both in terms of human life and in terms of economic costs. And so, I really want to make a plea for for leaders to recognize, both globally and nationally, that these investments are needed. They have to happen over the long haul. A lot of them are also recurrent expenditures, so it's not just the capital investments, it's also keeping the workforce going, keeping labs functioning, keeping, surveillance work ongoing. And, whatever we invest, all of our estimates show that those investments are tiny compared to the costs and the fallout of not investing. So at the pandemic fund, we've managed to mobilize about 1.7 billion, but we are working hard to mobilize more so that we can really get low and middle income countries prepared for the next pandemic.
Thank you, Priya. And on that point about sustainable financing, as Andrew mentioned earlier, I encourage you to engage with the FP Analytics research brief that my team produced on the road to 2030, and in particular achieving UHC. And as Priya mentioned, our research also demonstrates that even the slightest increases in annual GDP commitments for health, for primary health, for building health systems, the yields in terms of maternal health, neonatal health, combating non-communicable diseases, you name it, mental health, the prospective outputs are so much higher in terms of economic, but also ultimately people's well-being and the planet's well-being. And so I think that's a really, really important point, and I think a great place to end this segment. So thank you so much, Priya, and thank you so much, Hamilton, for joining us.
Thank you.
Thank you very much.
Thank you. And now for our next segment, I'd like to invite Gabriela Cuevas Baron to join me on stage for a one-on-one conversation on advancing universal health coverage.
Hi.
Hi, welcome.
Thank you. Thank you so much.
Please. All right, let's get started. Well, it's my honor and privilege to welcome and introduce Gabriela Cuevas Barón. She has been the co-chair of the UHC 2030 Steering Committee since 2021. And she's also a member of the UHC Movement Political Advisory Panel since 2020. In addition, she is a commissioner at the Chatham House Commission for Universal Health and was a member of the Lancet COVID-19 Commission, where she served as co-chair of the Commission's Task Force on Humanitarian Relief, Social Protection, and Vulnerable Groups. So immense experience, and it's really an honor and a privilege to have you with us today.
Thank you very much.
To get started, I'd love to pick up on a thread of conversation we were just having in the previous segment, and in particular as relates to the high-level meeting on universal health coverage that's coming in September. What are your expectations for the political declaration that is hopefully going to be coming out of this meeting, and how can we ensure that people's needs are well represented?
Thank you very much, Majesha, for this kind and generous introduction. Thank you very much to all of you for being part of this dialogue. You made two very important questions. One about the political declaration. Well, the first issue that we must consider is that we are going to have here all heads of state, or at least at ministerial level, explaining to the General Assembly what have they done in terms of achieving universal health coverage during a super complicated time for humanity. And of course, they have to show us which are going to be the next commitments, which is the way each country is going to take in order to achieve UHC by 2030, as it was established and adopted and committed for all the 2030 agenda. So it is not a new commitment, but this is going to be a great movement in terms of renewing those commitments and to explain which is going to be the implementation process. So that's the first part. The second one is, how are these commitments going to be reliable? How can we imagine? How can we be sure about the years to come? So I really expect that we're going to hear clear and actionable commitments. I think that's very important on how each country, each government mostly, is going to strengthen their health system and how they are going to place primary healthcare as the foundation. I think that one of the most important challenges is how we are going to place people at the center of all debates, at all decisions, and then how we're going to translate these wonderful global commitments into tangible actions, into national and local realities. And then the second question about how are we going to be sure that people's needs are going to be reflected? I believe that's part of the conversations that we are having these days. That's part of the nature of having the hearings and having civil society represented at the table. But it is not going to be only civil society. It's about bringing the private sector. It's about international organizations. It's about governments. It's about parliamentarians, about local governments. We need to understand that building a UHC that's strengthening health systems, it's everyone's commitments. Mm-hmm. It's everyone's responsibility. So yes, the first step is to place people at the center of all decisions. And I would like to ask you all to be part of our action agenda, which is very important. And it has 8 very important points in terms of, again, placing people at the center of all decisions, making governments responsible and accountable, mm-hmm. and understanding that civil society plays a major role in terms of representing people, including everyone, and accountability purposes.
Well, you talked about the various stakeholders that are going to be critical to this. And one question I'd love to pick up on that from your comments is, what's the role of the private sector in terms of, achieving UHC? What would you like to see coming out of the private sector?
Well, here, of course, I have to speak about UHC 2030 and our composition. One of the things I love about this organization is that we are a multi-stakeholder organization. We have civil society, we have member states, we have international organizations, and we have the private sector represented at our steering committee. And why we do that? Because we believe that all different stakeholders, all different industries, all different parts of society must be part of building and strengthening health systems. If we take a look of the pandemic, but also about all the health components, well, we know that private sector is a very important component. Perhaps one of the challenges is how can we improve the dialogue and understanding between governments, civil society, and private sector. It is not about finding each other as the enemy. It's about finding each other as a partner, as someone you need in order to find the common good. And that is guaranteeing health for all. So I believe in cooperation, I believe in dialogue and understanding, and private sector plays a very important role in that regard.
Well, thank you for that. And I think that's a perfect segue for a broader conversation that we're going to have as part of our next segment. And I'd love to welcome Leisha McCormick, Dr. Prashant Yadav, and Anna Caravaggio to the stage.
Welcome. Thank you. Hi. Good to see you. Nice to meet you. I'm Anna.
Okay. Well, it's now my pleasure to welcome a distinguished panel for the next segment in our discussion. And on screen, we have Dr. Prashant Yadav, who is a senior fellow at the Center for Global Development, and he's also a lecturer at Harvard Medical School. We're so delighted to have you with us. Thank you, Prashant, for joining us virtually. In addition to Gabriella in the middle, I'm delighted to welcome Leisha McCormick. Leisha is the Chief Executive Officer of Last Mile Health, which is leading a team of more than 200 people to strengthen community health systems in partnership with governments across Africa. And at the far end, it's my pleasure to welcome Anna Caravaggio. And Anna has been with Johnson & Johnson for a good while, where she is the Vice President of Global Public Health Franchises. Anna, thank you so much for being here. I'd love to start this segment of the discussion specifically with you, Leisha. We've heard a lot about primary health care and the importance of it within UHC and also earlier in terms of pandemic preparedness. And so let me ask you this. In your view, what is the role of primary health care in achieving universal health coverage? And what are some promising approaches for strengthening PHC when it comes to low and middle income countries in particular?
Thank you, Maisha. It's a great question. The simple fact is that we live in a world where illness is universal and access to healthcare is not. I think we've heard some of the panelists and prior speakers talk a bit about health inequity and health equity and the quest for greater health equity. One of the areas where we are consistently seeing that health inequity is the greatest is in remote rural areas. So geographically distributed pockets across the globe where about 2 billion people live out of reach of current health services. I think a lot of what we're seeing is that in these remote rural areas, there's a triple bias in effect. Public sector is not necessarily prioritizing these remote rural communities because there's less density in terms of constituents. The private sector isn't necessarily always prioritizing because there's not as much market potential, and the social sector is not prioritizing because it's seen as cost prohibitive. But a lot of what we're talking about in terms of both achieving universal health coverage and pandemic prevention requires that we not leave remote rural communities out. Much of what we're seeing, and I think a very plausible solution, is around health workforce investment. And I think the initiative and sort of the momentum, particularly around community health workforce and professionalized community health workforce, we see as extremely promising. In Liberia, we saw professionalized community health workers respond to Ebola in 2014, 2015. We're also seeing that these health workers are capable of delivering integrated services. As of late, about 70% of child malaria care is being delivered by these community health workers. And there's also the ability to make sure that there's community trust and demand in the health system around things like vaccine delivery.
Well, picking up on that exact last point that you made about delivery and continuing from the previous segment in terms of understanding the ecosystem and the infrastructure and what it takes to turn, for example, vaccines into shots in arms, I'd love to turn to Prashant. Prashant, just to first confirm, can you hear us all right?
I hear you fine, Marcin. Thank you.
Okay, fantastic. I'd love to ask you, where does strengthening global health supply chains fit into the UHC agenda? For example, why is it important to improve access to essential medicines, treatments, and tests in low and middle income countries, and how does that contribute to building resilience?
Thank you. So I think one, we have to start with a clear understanding that supply chains are a very important component, but in many ways the backbone of the health system. We often think the role of the supply chain is to get health products to populations, and beneficiaries, patients, caregivers. But I think oftentimes we forget that in addition to getting medicines and health products and vaccines to patients, health supply chains play another two important roles. The first one is, like Leisha talked about, healthcare workers who serve rural communities. The morale of health workforce depends upon having health products available, whether it's in the clinic, at the health post, or if they are doing rounds in the community. Without that, they are at a very low level of morale. Our ability to incentivize, motivate, and get health professionals to go and serve rural communities drops dramatically if we cannot get them medicines and health products. Secondly, our ability to capture information about the health system is not just coming from records and administrative data, it also comes from dispensing data and knowing the volume of malaria medicines or RDTs that were dispensed in a given community, and then trying to correlate that with the number of cases recorded in the administrative data. That's what allows us to build a careful feedback loop in the health system. So we've got to remember the three important functions of the supply chain: getting products to people, keeping healthcare professionals, their morale high, and then bringing back vital information sets for health systems planning. Now, what we know is that out-of-pocket payments remain high and are one of the stumbling blocks because of which we cannot progress as fast and accelerate our UHC ambitions. And while out-of-pocket payments could be for service delivery, we know that in low and middle income countries, a more significant portion of out-of-pocket payment goes when people cannot get medicines either in a public clinic, or they find it that the retail prices are too high when they go to a private pharmacy or a private clinic. That is something we can fix with supply chains today. The last 3 years have been a somber reminder of the systems that don't exist, but they've also been a very good and in some ways a congratulatory state that companies, governments, and other actors within countries have worked hard. I mean, yes, we had delays in access to vaccines, but essential medicine stockouts or essential medicine supply disruptions were not that widespread as we had feared at the start of the pandemic. That was largely because we do have a system where companies, the local agents, distributors, and governments come together in some sort of collaborative manner. A third and very important point I want to highlight is there are a lot of new business model and tech-led innovations that are starting in the healthcare supply chain across low and middle income countries, across regions in Africa, in LATAM, in South Asia, in Southeast Asia, and everywhere. And these are young entrepreneurs who've seen firsthand why medicine not being available in a government clinic or being too expensive in a private pharmacy impacts their community. They've taken their training, sometimes in technology, sometimes in business innovation, and have built enterprises which are solving this problem faster than what we've been able to solve historically. They are creating new opportunities for pharmaceutical companies who have traditionally depended upon either working exclusively with the government supply chain or through large-scale conventional wholesalers and distributors to find a new avenue. And this new avenue is a real exciting area which helps us build all of the performance objectives that you mentioned: resilience, speed, efficiency, So I think that's where I feel we've got to do some more and bring more actors to look at what the new innovation that's happening within countries led mostly by young entrepreneurs.
Thank you, and I appreciate that point a lot because it is about looking forward and harnessing opportunities and untapped potential. And you know, one of the things that we were talking about earlier with the ambassador on stage was Japan's experience in terms of TB and the remarkable progress there and what it took to achieve that result. And I'd love to turn to you, Anna, next, and specifically ask you, how do global efforts to eradicate TB, especially in low and middle income countries, drive forward the UHC agenda? Can you help us make that connection? And how is industry supporting those efforts?
Thanks so much, and thank you so much for inviting me to speak here today. When you look at the case of TB, it's the largest, or was the largest, infectious disease killer in the world until COVID eclipsed it, and it's set to hold that title again, not a title that's well appreciated, but is the reality. And when you look at the people that are most affected by TB, it is those people in low and middle income countries, the most vulnerable of people, and really the ones that would benefit most from UHC. The COVID case really helped us to understand what does it take to respond to a pandemic. We've heard so much about that already this evening. And those services that were there and ready to serve TB patients were the ones that were most activated in the response to COVID because of the nature of the respiratory illness. So I think it really does point to the similarities between being prepared for TB and for UHC and pandemic. The connection between these three initiatives has really, unfortunately, become clear through the COVID experience. J&J, through our partnership with the Stop TB private sector constituency, just launched a report that really highlighted some of these connections between TB and pandemic preparedness, really focusing on how finding some of the missing millions, which is what we call it in TB, is really a critical initiative to ending TB or to stop TB. But finding those missing millions means investing in diagnostic tools, and these tools can be repurposed and really can be used to explore and diagnose other conditions other than TB. So these investments in AI and other diagnostic technologies are critical not only in the effort to end TB, but also in UHC and in pandemic preparedness.
Thank you, Anna. And something that you mentioned that I think is so interesting is how investments in one area can pay dividends beyond that initial area of investment and across the board. And this is really important. And you mentioned also the role of AI. And one of the things we know, and there's growing research around this, is that there is a health care workforce shortage globally, and that there's also a broader workforce transition that's coming. And Gabriela, I'd love to turn to you and then bring the others in on this, but specifically, can you talk a little bit about how can international collaboration be leveraged to address the challenges faced by the health workforce and healthcare supply chains? And so from your perspective, what are some initiatives or recommendations that you would put forward in terms of that transition?
Yes, of course. I think that we cannot imagine UHC if we do not have a global or national or local health workforce. That's clear. We understood that also during the pandemic, but every time that we have to look for a doctor, for a nurse, for someone who helps us in the most desperate moments. So the real challenge is how are we going to find the global shortfall of over 10 million health workers? And that's a lot. But that has a lot of challenges behind that. First, the global inequity. The most pressing challenge is that this shortfall is related to global migration, because some of these workers are traveling from the low income countries to the rich ones. So the people that needs the most in terms of having a medical attention is precisely the one who is exporting that talent, that health workforce. So that's one of the challenges. Yes, we do have a lot of recommendations. Again, that is included in our action agenda, so please take a look to that. We need you to be part of it. And we believe that, first of all, we need to change the working environment. It's not an easy environment, and you know that very well, so I won't go into that issue. But the second one is we need to have equal representation. While women are making 70% of the health workforce, well, when it comes to decision-making processes, we are only 25% of the people sitting at the table. And that goes for the World Health Assembly. That goes to many different spheres. So we need to change the rules and to acknowledge that the health workforce is mostly composed by women. We were at the front line of the pandemic, and it is time to change the environment, and it is time to change the rules and to place women also at those decision-making processes.
Thank you for those points, and especially this last one. But to go back to an earlier point that you made about migration and out-migration, this is so important. And again, the FP Analytics research brief on the road to 2030, this is one of the topics we cover in that analysis, because as you correctly pointed out, there is a brain drain that's happening. And what we're seeing is a lot of talent from low and middle income countries migrating to high-income countries because there are opportunities and because there's a workforce shortage. And obviously that has huge implications in terms of the future of primary health care, of strengthening health systems. And Lisha, I'd love to turn to you and bring you in on this question. You know, you and your organization are very much on the front lines of reaching the most underserved communities. And so that workforce transition has huge implications. And so can you talk a little bit about, from your perspective, what needs to happen in terms of addressing the workforce shortage and the transition to come, and how that fits into achieving UHC?
Absolutely. So, you know, I think two specific ideas and solutions that come to mind are improving access to care and professionalization of community-based providers. I think that in that solution, though, it is critically important when you actually start to hear a lot of commotion around community health workforce that we are not simply task dumping on folks that are set up for failure because they're not provided with the inputs and the support that are required to be able to be effective in their roles. I think we have seen over the past 10 years the dialogue shift in many ways in which there is an understanding that the best means of delivering primary care is through a very well-equipped team of healthcare practitioners. So enabling each practitioner to operate at the top of their license, in which a community-based health worker is able to get ahead of more complicated cases, thus alleviating the burden that may exist with healthcare workers that are actually at primary health facilities. So much of what we're really focusing on, and I think the huge opportunity, particularly in low and middle income countries, is around making sure that community health workers are receiving the training, the skills, the salaries, and the supervision that they require, as well as the supplies, so that they're able to be effective. The last point that I would like to make, just building upon your excellent point, is really related to the need to talk about professionalization of community-based providers in the same sentence as we talk about gender equity. Mm-hmm. The point made around 70% of the global health workforce being women is absolutely spot on. One of the things that we see when we start to introduce pay into a community-based workforce that has historically been seen as volunteers, and volunteers that have principally been women, and that is not an accident, is that you see women get pushed out of the workforce. So making sure that introduction of pay to these providers who are doing a service and are acting as professionals is also talked about, and making sure that there's recognition that women need to be able to be preserved and supported and maintained within this workforce is essential to effective health delivery.
Absolutely, and to your point on the professionalization of the workforce, I think it's also really important to realize, yes, we're talking about doctors and nurses, but we're talking about scientists, we're talking about individuals that are specialized in all kinds of technology that are critical to the future of healthcare. And obviously, in terms of industry and the role of industry, this is a huge issue. And so, Anna, on this question of the workforce transition, and the road to 2030 and to achieving UHC. How do you, from your vantage point at Johnson & Johnson, approach this question of the workforce transition, and what are you hoping to see happen more?
I mean, in the case of TB or in HIV and in many of the areas that we work in, we see that community health workers all the way up to physicians, they're so critical in the delivery of care in every therapeutic area, but particularly in low and middle income countries. And so J&J was one of the founding sponsors of the Africa Frontline First Catalytic Fund hosted by the Global Fund. And this is a critical investment that we see in healthcare and in universal health coverage, but also making sure that as we deliver medicines as industry, that these medicines reach their intended patients, right? Because keeping them in the labs and in supplies and in pharmacies doesn't do much good if it doesn't reach the patients that it needs to. So investing in the professionalism and the training is a critical aspect of it as well, and that's what the fund really focuses on, is appropriate training for frontline workers.
That last point, I think, is also a great transition to the economic question and the question of financing. And Prashant, I'd love to go to you next and ask you a little bit about how can blended finance approaches and partnerships, whether that's with insurance companies or with other stakeholders in the broader healthcare ecosystem, help to effectively contribute to the achievement of UHC? How do we balance blended financing approaches to help ensure equitable access and financial stability, for example, in the health sector?
Thanks. So I think two things I'd like to contribute to this. The first is, when we think about building the delivery infrastructure, whatever is needed to get medicines and health products from once they are outside the factory gate, like Anna said, to the patient, the operating cost of running it is something we assume that governments pay out of health sector budgets, whether it's to purchase medicines or to pay salaries of healthcare professionals. But the fixed cost of building that infrastructure is too large for public spending alone to cover that, right? That requires building infrastructure of various forms, IT, hospitals, supply chain warehouses, and so on. And that's, to me, one area where blended finance and unlocking private capital by using public finance to either underwrite risks or ensure that private capital and its risk return asks are matched with what we can offer. There are numerous examples of using blended finance for making fixed capital investments in the delivery infrastructure. There are new initiatives and institutions that have come up. There is, within the supply chain area, we have the Africa Research Center, which brings together public and private stakeholders to contribute in ways that fit best with the kind of capital and the kind of operating revenue that they can add. So I think that's an area which we need to explore more. We need to take smaller projects that are happening and seem good when we talk about them at small scale, and do that at much larger scale, and do that with large quantums of private capital going into building the delivery infrastructure. We have the global agencies who have both the mandate and the resourcing to do it now. It's just that the partnership structures are still nascent in making that happen, and they need to be strengthened and amplified.
Thank you, Prashant. Before we finish up the panel discussion, I'd love to see if anyone in the audience has any questions that they'd like to ask. And I think we have a microphone. Yes, a microphone. If I could just ask you to very briefly say your name and your organization, and then please make sure your question ends with a question mark at the end. We'll go to this lady right there.
Thank you. So I'm Nicole. Can you hear me? Okay. I'm Nicole Assoon, and I'm at the Global Health Impact Project at Binghamton University. Okay. COVID-19 revealed that the world is woefully unprepared for future pandemics. And I think that the international community has to come together to finance new technologies development. But we can't continue to provide that financing without requiring good access conditions on resulting technologies, and similarly for other public and private sector investment. So as CEPI does pay for phase 1, phase 2 trials, but then I think we should pay for the phase 3 trials and own the technology so that we can make those licenses available for manufacturing globally. I'll end with a question.
Yes.
So I wanted to ask actually Last Mile Health, because I think it's really important work that you're doing to make those basic health system function. But I also worry that it's the flight of workers to rich countries is coming from the fact that we pay more. And so we're de-skilling the workforce in poorer countries. So I wonder if there's any other ways of kind of scaling up that kind of effort you're doing that would end up providing a workforce that was, equitable as well as
Thank you.
effective.
Alicia, over to you.
Sure. Well, thank you. I appreciate the points you're making and also the question. I think, yes, there is enormous potential to scale up a gender equitable, well-equipped, professionalized community health workforce. And I think Anna made a really great point earlier around an initiative that's currently being hosted at the Global Fund called Africa Frontline First. J&J and Last Mile Health have been part of that. And I think much of what we're seeing, and this kind of comes back a little bit, Maisha, to the question related to financing, is that there's often been significant public sector financing available for public health initiatives and for health services. Sometimes it's been quite verticalized, so it's been very condition specific, in which there's financing that is available for HIV and TB here and malaria here, and then you have immunizations in this separate pot. And that's not the way that patients present, right? That's also when you're working in more resource-constrained settings where you're actually requiring a single provider to be the principal point of contact for entry into the health system, that they are best supported to be able to provide trusted, caring, diagnostic, and curative services. So I think where we're able to actually take a look through Africa Frontline First around greater integration and inclusivity of how financing is structured, that is a much more patient-centered approach. And I think it is very possible to tap into the incredible human capital and human potential that exists across the continent of Africa around these community-based providers of care. So I hope that that's a bit helpful.
Thank you, Alicia. Maybe one more question before we wrap up. The gentleman in the back. And again, please keep it brief and make sure it ends in a question mark so we can hear the most out of our panel.
Okay, thank you. Thank you very much. I think Alicia opened up with a question that disease is universal, but access isn't. And I think one of the things that we wrestle with, that a lot of these things are political choices, right? We decide not to do certain things. And I think one of the ways that can help us around that is access to good data and good information flows. And I haven't really heard anything about how we can invest in improving global health management information systems. So there are bi-directional flows. And we can start thinking about breaking up how health professionals work. My name is Russell Rensburg. I'm from the Rural Health Advocacy Project in South Africa. Thank you.
Thank you for that, and I think that's such an important question. And maybe we'll open it up to all of you to just very briefly, Prashant, including you. And the question was about information management systems and the role of data and transparency. Would you like to start, Prashant, and then I'll come to the
Yes.
panel in person?
I think an extremely important point. I think we all know how important data is. Much of our health system planning, our ability to bring greater efficiency and value for money depends upon collecting data and closing the loop and doing things with our, not necessarily based on top-down planning, but based on bottom-up data. Now, it is not a new endeavor. I think many of us, including those of you who are in the room, have been working on creating better management information systems for health data. The challenges are that the incentives for healthcare professionals at the very last mile, the kinds of groups that Alicia is talking about, we have to ask, they have a busy job, they have a lot of things to do, and on top of that, are we making it easy for them? Are we creating the right incentives for them? And are we giving them something in return? That something in return is not a monetary incentive, it's accountability and action. So if I'm a healthcare professional that's going out into the community and I'm entering data about disease burden, use, lots of other things, in return, would I get back something as improved performance? And so far, that link hasn't happened, because of which attempts to bring new technology, new systems haven't taken off in the ways that we all want to. So I think we just have to close the loop. Every time somebody enters data, we've got to give them better performance in return for entering data. That's my quick take.
Thank you. And maybe over to the panel to add anything that you'd like to add on this question about data management, data transparency, and access. Anna or Gabriella?
That's way outside of my expertise, but I will say I spent some time in India recently and saw a technology interface between a frontline healthcare worker. And I think that was so interesting about that technology is that it allowed the healthcare worker to serve their patient better. And I think that that's what the inherent incentive is for healthcare workers, is if it unlocks that relationship with patient in an integrated way across therapeutic areas, as opposed to this technology for TB and this one for maternal health, it really, it captures data. So that's way outside my expertise, but it was very inspiring because the back end, the data collection is very, very rich, but it really did unlock that patient healthcare worker relationship, which I know you'd be happy to hear.
Yeah, I am also not an expert on that field, but part of what we have done at UHC 2030 is to understand accountability as a basic responsibility for politicians in general, for parliamentarians, and also where civil society plays a very important role. I mean, yes, it is a matter of political will. For sure, it is about legislation, it is about budget allocation. If there is no budget, there is not going to happen anything. But if we see, for example, what happened during the pandemic is that even some countries or some scientists decided not to share their findings. So I think, yes, it is about data, but it is also about a general possibility of cooperation instead of perverse incentives of competition and profits. So I think that from the government side, it is about transparency, it is accountability, it is about strengthening a civil society voice, willing to say my government is lying or I am supporting my government with these purposes. I believe that it involves a whole of society, a whole of government approach, because data is not a monopoly. Yeah, of course, doctors are a very important component, a basic one. But it also comes from the top of those decisions. If a government decides to come to the UN and says that everything is beautiful, well, I think that their citizens might have different data. So we all have to be part of that discussion. And one of the I think more interesting exercises that we develop, and you can find it in our website, is we publish every year a country profile. And how do we get all that information? It is from public consultations and, of course, government data. But civil society, again, I believe, plays a very important role in that regard.
I think that's such an important and excellent point for us to end this discussion, which is what kind of data are we talking about and who does it serve? And certainly if this is an issue that you're interested in, our team at FP Analytics did a research brief specifically on these questions, and you're welcome to check it out at fpanalytics.foreignpolicy.com to look specifically at the role of, for example, digitization of data and transparency, increasing access and systems for access, whether digitally or in other forms as well. So thank you so much, this wonderful panel, and for this discussion.
Thank you.
And it's my pleasure now to hand it over to Andrew Solinger, CEO of Foreign and publisher of Foreign Policy, for our final segment with Dr. Thomas Cuny.
Thank you, Maisha. Great discussion. Wow, that was an impressive discussion. I hope you agree. There's been so many impressive discussions over the course of the day. It's my privilege now to wrap this up with Thomas Cuny, IFPMA's Director General. He's got an august set of titles: CEO of Biopharmaceutical, CEO Roundtable. He helped create the AMR Action Fund and is very involved in AMR. He's the chair of business at OECD Health Committee. But on his resume, what I'm most impressed with is the time you spent at the higher calling of journalism in your past, which is near and dear to my heart. So I know you're inquisitive as well, and I look forward to this discussion with you.
Thank you very much, Andrew. Of course, there the highlight was I was a member of the All England Lawn Tennis Writers Association. There's not much which can beat that.
That is a fantastic one. Wimbledon, I see, might be in your future. So a fantastic set of discussions as we just discussed. I wanted to, a few notes that I took on some of the top points. We talked about, most recently, the lack of solidarity amongst the international community in the face of the pandemic. The lack of an inclusive approach, system, architecture, the importance of financing. We talked about that a number of times. Most recently on the panel that we just heard, we talked about workforce shortfalls and the importance of inclusiveness by gender as well, all critical points. I'm just curious to hear those points. What others did you come away with? And I'd be very interested to hear what your number one takeaway was so far from these discussions.
Actually, a couple of elements. Some of them have been mentioned, some of them not that much. I think one of the key assets of what we learned in the pandemic is the importance of partnerships, the importance of multi-stakeholder partnerships. Early on in April 2020, when the ACT-A partnership was created, it was really a multi-stakeholder partnership. And, on the one hand, from an industry point of view, we could proudly say all the tests, treatments, and vaccines which got us out of the pandemic came from private sector. Mm-hmm. But they wouldn't have come as fast and as quick without the amazing partnership with regulatory agencies. Having a vaccine within 328 days from knowing the genomic sequence was an amazing feat, because the fastest vaccine ever took 4 years before that. At the same time, I think we also have to acknowledge the lack of equitable rollout.
Yes.
But there again, listening to the ambassador, I was thinking it didn't start that badly, because in March 21, within less than 2 months of WHO having approved the first emergency use license for a vaccine, you had significant shipments reaching Kigali, Accra, Nairobi, and Abidjan. On the very same day, the first shipments reached Tokyo. But then something intervened. We had the enormous surge of COVID in India, and the whole supply, which was destined to come out of India for Africa, for 2 reasons. It was the cheapest vaccines and least logistically challenging, dried up, and it took 7 months before the world community compensated that with dose sharing from the US and other parts. Therefore, in terms of lesson learned, I think we need to make sure that we don't compromise the innovation ecosystem which worked. Hamilton earlier this evening said, actually, companies like Moderna or BioNTech, they were not on the radar screen in 2020. If you would have asked me in March 2020, I expected, if I'm lucky, I may get the vaccine by June 21. If you had asked me which one, it wouldn't have been available for another 2.5 years. Moderna and BioNTech, with their mRNA research, largely funded by private investors. There was not much public money going into mRNA. When it came to scaling up, in particular, Moderna benefited for clinical trials, for scaling up from BARDA. I've heard, actually, in January 21, a European president, better remain unnamed, who said we all owe a lot of gratitude in Europe to the US taxpayer, because it was basically the US taxpayer which was the funding largest. But at the same time, we also have to very blatantly and openly say there was not much difference in terms of America First between Donald Trump and the Biden administration. It took 7 months, from the supply shortage in Africa before this dose sharing really started. And that's, for me, one of the lessons learned that caused an enormous anger in Africa. When I look at my friend Gitinji there in the back, and we are still suffering from it, and we need to do 2 things. One is, if you have seen Africa relying totally on foreign manufacturing, we need to work on better geographic diversity of manufacturing, but that will take 15 to 20 years. And we need, I think, to commit to sharing in real time That's what, by the way, IFPMA companies, which includes Moderna, which include Pfizer, J&J, many others, did come out with a statement that at the next pandemic, we are willing to, in real time, put aside part of production for vulnerable populations in low-income countries. But that will only work if the rich manufacturing countries or India accept that part of production will leave their country before every American, every British, or every Indian is vaccinated.
That is a very good point, and innovation is of no use if it can't reach those who most need it. So that is the most important thing. There are those who would say, of course, that the pharmaceutical industry is not part of the solution, but rather part of the problem. You know, that we were talking about issues around IP, around financing, around profits. What would you say to that debate?
Actually, when you look at the lessons from COVID-19, it wasn't the CDC, it wasn't public, it wasn't WHO scientists who came up with the tests, vaccines, and treatments. They did come out from private labs, but as again Hamilton said, we have seen tremendous partnership between academia, biotech, big pharma, among big pharma in industrialized and developing countries. Therefore, I do see also something which nobody has mentioned yet. I've never seen such a game-changing breakthrough for what I call tiered pricing. If you ask COVAX, Gavi, CEPI, WHO, COVAX paid the lowest price for every vaccine they used because companies understood that solidarity required that, you know, you had to provide affordable vaccines. When I look at, for example, I'm vaccinated against quite a number of things. Normally, these vaccines cost $250 plus per shot. The COVID vaccine, first, zero out-of-pocket payment, because in my country, same as in Japan, it was funded by the government. Yep. But actually, the cost for the government was about 1/10 of what I normally pay for a vaccine, even in a rich country.
Understood. Well, one thing I wanted to ask you is about moving forward. The WHO has just declared the COVID emergency over, but we're in a post-COVID emergency now. Based on all the discussions that we had today, we need to put in place new mechanisms, new innovation in order to prepare for the next crisis. Human memory is short. We have a growing list of polycrises, which we talked about at the start of this discussion: war, energy crises, financial crises, inequity. Do you think we'll remember and learn these lessons now, or is this going to stick? And aren't we already in our next pandemic, in some instances, an MMR pandemic?
I was born an optimist, but at the same time, at my age, you're also a realist. And as a realist, I'm not sure that we learned from what happened. When I was at the high-level OECD meeting in January, if I hadn't been there in 4 hours, nobody would have talked about health. When you look at kudos to Japan for putting health that high up on the G7 agenda, but when you look at AMR, Jim O'Neill and David Cameron put it on the G7 agenda back in 2014. Have we seen progress in terms of making research into antibiotics, which we desperately need, sustainable again? A Pasteur Act was close to passing end of last year, didn't. Not sure that in the current bipartisan partnership in the US Congress, it has a better chance this year. The European Union did come out with something, but I haven't really seen, the movements. And I mention AMR because Jim O'Neill in his study said by 2050, if nothing changes, 10 million people per year will die from antimicrobial resistance, which is more people dying from antimicrobial resistance than die from cancer every year. And have we seen really, the concern? Being Swiss, we are very concerned about these slowly melting glaciers. Now, I think we are concerned about climate change. Are we concerned about AMR as we should be? I doubt it.
A really sobering thought to end the discussion. I am encouraged, however, by the incredible passion and smart thoughts and work that is being done in this room today that you helped us convene. So I thank you very much for that and for all your efforts here, and for IFPMA for partnering with us. Thank you so very much. So we'll conclude it here, and I'm aware that we're standing right now between you and drinks as well. I just wanted to thank again IFPMA for their partnership in this endeavor, for all of you, our distinguished panelists, and those of you watching online as well. I do want to share that this is just one of several efforts that foreign policy undertakes in the health space. We have a health summit, our second annual Global Health Summit, that will convene on June 13th in Washington. It's a fascinating program. Some of the speakers include Christos Christou of Médecins Sans Frontières, Dr. Mathieu Diofala, the Health Minister of South Africa, Lady Rosalind Murata, the incoming chair of the Global Fund, Gail Smith of the One Campaign, Juan Pablo Uribe, and Thomas Cuny of IFPMA. Again, thank you very much. We hope you stay connected with us by signing up for our newsletters and our website and our social and our app. If you're not already a subscriber, flip over that card. You can use the QR code and subscribe. And please support FP. We thank you so much for joining us. And please do have a drink and keep the conversation going.